Good afternoon, friends. At the outset, I would like to thank Dr. Manvi and Venkatesh for giving me this wonderful opportunity to be here. I've been part of Arvind for almost 10, maybe 11 years. We worked at Arvind Madurai. That was a long time back, and maybe some of my colleagues will remember that. So I start my talk with your take-home message. And speaking on TASS versus early endophthalmitis, it's always better to err on the side of caution because you don't want to miss an infection. TASS, or toxic anterior segment syndrome, was first described by Monson in 1992. It has several other synonyms. It's also called a sterile postoperative endophthalmitis or toxic endothelial cell destruction syndrome. So when we have to differentiate between early infection and inflammation, it's always better that we have everything ready so that the infection does not progress. This is confounded by the fact that there is an overlap of symptoms and an overlap of signs between early infection as well as inflammation. A culture positive result is only single criteria which confirms that you are dealing with an infection and not an inflammation. However, culture positivity in endophthalmitis may be seen in about 60 to 70% of cases. We have about 30 to 40% of cases which are culture negative. This is Sunny's data. I hope he remembers this. The incidence of TASS is about 0.22%. Maybe it occurs 1 in about 1,000 cases, more frequent than postoperative endophthalmitis. If you look at the symptoms of postoperative endophthalmitis, ocular pain, blurred vision, and redness. Ocular pain was once considered the characteristic of postoperative endophthalmitis, may also be seen in a very severe case of TASS when there is a lot of inflammation in the front of the eye. A degree of suspicion is essential for early diagnosis. When you see any postoperative reaction that is disproportionate to the amount of intraoperative manipulation that has occurred during surgery, you have to keep postoperative infection in mind. Early signs of postoperative endophthalmitis includes a streaky hyperpan, better seen with transverse illumination, fibrinous exudates over the surface of the intraocular lens, vitreous haze. The presence of conjunctival chemosis and lid edema may not be present. I posted a picture of a person who has a recurrent Acinetobacter baumannii infection. There's hardly any external inflammation. The eye is absolutely quiet and white compared to the amount of muck that is sitting in the front of the eye. The patient may have pain and visual loss that is disproportionate to the clinical signs. Look for the presence of a small hyperpan, the presence of vitritis, look for cells in the vitreous or some amount of media haze. Presence of retinal periphlebitis is also a sign of early endophthalmitis. And if your vitritis is worsening, you have to step in immediately. Look for the presence of corneal edema, which is one of the classical distinguishing signs between TASS and postoperative endophthalmitis. A person with TASS may have severe corneal edema disproportionate to the amount of anterior segment reaction. It is an edema which extends limbus to limbus. Let us look at this patient on the first post-op day. He has a vision of 6/60. There is no pain or lid edema, but there are plenty of Descemet's folds. Corneal edema, there is a small exudative membrane which is sitting on the surface of the IOL. The IOP is raised. There is still a fairly good red glow. I converted my presentation from the keynote to PowerPoint and the alignment is all skewed. I hope you'll forgive me. So going back to TASS, it's an acute sterile anterior segment inflammation. It's uneventful following an uneventful cataract surgery or any other anterior segment procedure. There are also variations from this where TASS can occur, especially following intravitreal injection. It has been reported with bevacizumab. It is a result of a non-infectious toxic insult at the time of surgery. There's a rapid onset of inflammatory reaction, very much simulating an acute postoperative endophthalmitis. So based on the clinical features, the rapid onset, unlike endophthalmitis, which takes at least almost 2 days to set in, it occurs within 12 to 24 hours. There is an increased cell and flare in the anterior segment, fibrinous exudate, hyperpan, and classically these cases occur in clusters. And always the culture should be sterile to make a diagnosis of TASS. I'll just pick out the classical features. The presence of pain is characteristic of postoperative endophthalmitis, may be mild or absent in TASS. Anterior chamber reaction, a moderate hyperpan may be present in about 75% of cases of endophthalmitis. Rare to see a hyperpan in early endophthalmitis, while severe fibrinous exudate filling the anterior chamber is seen in all cases of TASS. The corneal edema is severe, extending from limbus to limbus. The pupil is usually dilated and fixed, while the pupil in early postoperative endophthalmitis is resistant to dilatation. The IOP may not be raised initially, but once the TASS settles down, there may be increase in intraocular pressure. So what do you do if the patient who has excessive reaction in the anterior chamber in the first postoperative day? In my own clinic, I make the patient sit in my OP itself, start him on topical antibiotics, steroid, systemic antibiotic, see him every few hours and see whether it is settling down or not. If I find that the reaction is progressing, I post him immediately for a vitreous biopsy and culture and give intravitreal antibiotics while continuing the conservative regimen. If he is improving, I intensify the steroid therapy. So let us look at the clinical course of TASS. Once you have obtained your culture and sensitivity report and it is negative, even before that, you take steps to suppress the inflammatory response, start the patient on topical steroids as frequently as possible. If there is a lot of fibrinous reaction in the anterior chamber, you can use TPA. It's very rarely used now, and supportive measures such as mydriatics, cycloplegics, and NSAIDs can be given. Slit lamp examination has to be carried out every few hourly, record the intraocular pressure, look for any precipitating matter such as residual cortex, residual viscoelastic, or maybe antibiotic ointment in the anterior chamber. Look also for indications that it could be an infection such as a suture reaction or infiltration, presence of a wound leak, vitreous wick, inadvertent bleb or exudation within a filtering bleb. A severe fibrinous reaction can be treated with intracameral injection of streptokinase. It is also associated with other complications such as presence of periorbital pain, chamber hemorrhages, and aqueous turbidity. If you have a mild case of TASS, the recovery occurs within 2 to 3 weeks' time with hardly any sequelae, but severe cases do leave behind sequelae. You may have an Uret-Savelia syndrome with a fixed dilating pupil which is unresponsive to either myotics or mydriatics. There may be permanent damage to the trabecular meshwork resulting in ocular hypertension or glaucoma, corneal decompensation and a pseudophakic bullous keratopathy, and fibrin in the anterior chamber may be conducive for epithelial ingrowth into the anterior chamber. What is more important than treatment is to understand why a cluster of TASS has occurred in your practice. You have to zero in on the cause and look for a strategy to prevent future outbreaks in your setup. So what are the possible causes of TASS? It could be a contamination in the irrigating solutions and medication. Most importantly, when you are using enzymatic detergents to clean the instruments in between cases, and when your theatre staff cut corners and do not clean out all the enzymatic detergents, or if you're using an ultrasonic bath in which the water is not drained after each use, the residue may accumulate on the instrument and may be introduced into the eye during surgery, resulting in TASS. Do not use tap water for cleaning instruments. Use either distilled water or deionized water. Even if you take all these precautions, there may be endotoxins, which are heat stable, which can accumulate on especially reusable cannulas. So as far as possible, avoid reusable cannulas. Residue of OVD, which is one of the most important causes of TASS, may build up on instruments and handpieces. So this is a work done by the TASS task force. The report came out in 2009 looking at the common cause of TASS, and the most important cause responsible for an outbreak of TASS was inadequate cleaning of the reusable instruments. You have to flush out instruments with port using an 120 cc of distilled water or deionized water, and sometimes when the timing between two cases is short, when there is a lot of turnover in the theatre or you are not adequately staffed, the theatre staff may cut corners and may not flush with the adequate amount of fluid, and the port may get occluded. In this report, it was noted that 40% of the surgeons noted occluded port during surgery. Another important cause is the use of enzymatic cleaners and detergents. They are not of the appropriate concentration or pH, and use of reusable instruments, which should not be done if possible. Even after cleaning the instruments, proper maintenance of the instrument is very important, and the instrument, once it is dried, has to be placed on a lint-free surface. Otherwise, even the lint which goes into the eye can cause TASS. Endotoxins is another important factor. This is a phaco probe with an endotoxin sitting on it, with the OVD covering its surface. So to prevent TASS, you minimize contamination with toxic material. Intraoperatively, do a thorough cortical cleanup. Do not leave behind any cortex or residual viscoelastic. The cleaning and sterilization process has to be reassessed in your theater at periodic intervals. For the phaco machine, check for backflush and other possible contamination, and avoid preservatives in the intraocular solutions. When you have an outbreak of TASS, it is important to have a product questionnaire. Look at each and every product that you are using inside the eye. Look at the expiry date. Look for contamination. If you are using an intracameral anesthetic, remember that the OVD will retain the anesthetic in the eye for longer periods of time. Certain preservatives, such as epinephrine that you add to BSS, may have bisulfite as a preservative, which can result in TASS. The intracameral antibiotic that you use may be improperly diluted, and residual viscoelastic can retain enzymatic detergents, and the ultrasonic bath, which is not emptied after each use, can also lead to TASS. You should have an instrument reprocessing questionnaire and ask yourself whether you can give adequate time between cases. Ask the surgeon whether they note for occluded tips during surgery. Do you ask yourself whether you have rinsed your instruments in deionized or distilled water? And do you clean your ultrasound bath after each use? In an outbreak of TASS, all the members of the surgical team should be actively and honestly involved in trying to find out how this clustering of cases has occurred. You have to review all the operating theater protocols, evaluate cleaning and sterilization procedures. Although you have a set protocol in your theater, the procedure has to be evaluated periodically, even if you don't have an outbreak of TASS. Analysis of all medications and fluids should also be done. There is an association called the TASS Task Force. Their questionnaire is available online since 2007. 2 centers in the US, the University of Utah and Emory, are mainly manning this force. You can report your clustering of cases to them. They also ask for associated information such as your protocol for instrument sterilization and cleaning technique, and all the products that you use, including the batch number and the expiry date, has to be given to them. In that way, we have data from all over the world to analyze. So when you follow up your patient who has a sterile postoperative inflammation, it's important to do a gonioscopy, look at the angle. These patients may have recalcitrant glaucoma, and also do a specular microscopy to assess the corneal integrity. There is one such patient who had a sterile postoperative reaction, which cleared very well with steroid therapy. There are certain variants. You may have delayed onset TASS, as reported by Jahan et al., 10 cases of TASS following cataract surgery, which is because of the residual mercury polishing compound on the memory lens. There is also TASS-like sterile postoperative endophthalmitis reported after intravitreal bevacizumab injection. Here, the difference from the classical TASS was the posterior segment of the eye was also involved. TASS and intracameral medication, especially vancomycin, reported in about 20% of cases. Preservatives and stabilizers used with epinephrine that you inject into your irrigating fluid to keep the pupil dilated. Preserved lidocaine gel, bevacizumab, and BAL. These are other cases associated with TASS. Since 2006, since the formation of the TASS task force, there has been an increasing awareness about TASS. This has resulted in improved instrument cleaning, adequate handpiece flushing volumes, the use of deionized and distilled water, and decreased use of reusable cannulas. But however, still in certain centers, enzymatic detergents are used and ultrasonic baths are also used. So the precautions that are necessary in using these 2 entities should be kept in mind when cleaning instruments. I thank you very much for your kind attention.